This village is a facility for more than 100, around 100 uh, elders resident, and it was built after the tsunami. So because this is a very great place to start the community palliative care conversation. So before that conversation, I would request to you have a look at a small video clip which is about our village, which is this Tamrai Kulam Elders Village. Can we have a video over the screen?
Everyone appreciates Krishna's melodious prayers, but not many know about the pain she hides behind them. She lost both her children early. In their old age, Krishna and her husband lost all support. The case of Kasturi is equally moving. Being illiterate, physically challenged, and with several old age-related ailments, 70-year-old Kasturi became a sad story of neglect. Krishna, Kasturi, and many others like them found the warmth of a home again at the Tamrai Kulam Elders Village, or TEV, the first home for the aged constructed by HelpAge India. Viewers of NDTV donated generously for this home to become a reality. Situated at Kadalur, about 20 kilometers from Puducherry, the Tamrai Kulam Elders Village, or TEV, gives them a chance to live a life of dignity. The village is recognized as a model old age residential project by the government of Tamil Nadu. This is a free stay facility for the rural poor and can accommodate 100 residents.
This is about the Tamrai Kulam Elders Village. So before getting into the conversation further, I would request our HelpAge India's state head, Mr. Edwin, to give the brief overview how it was built and why it was built. To Edwin, to you.
Thank you, ma'am. Good afternoon and a warm welcome to Tamrai Kulam Elders Village, the first of its kind model that has been developed to take care of the destitute and abandoned elderly. So in 2004, December, same time, December 26th, tsunami hit the south coast of Tamil Nadu, and Kadalur and Nagapattinam districts took the brunt of the impact, and more people perished within fractions of seconds, and many could not be bodies could not be recovered as well, so they were buried. So it was a very disastrous moment, not only for the families but for the entire nation. And it took so much of time and effort and years for people to come out of this, and still many families have not come out of this shock. And as in every disaster scenario, the most affected were the children, women, and the elderly people. And of course, there was a lot of support that a lot of NGOs came in, a lot of support was provided for children. A lot of support came in for women, reconstruction of houses, providing livelihood support, but elderlies were left out. And that's the time HelpAge thought that HelpAge should step in and not only just provide relief, but also a rehabilitation process. And our appeal was very well accepted by NDTV, and through the viewers, we were able to raise substantial amount, and HelpAge on its part, we also put in our resources. And finally, this building was, this entire premises was inaugurated on December 17, 2007. Primarily with the focus of accommodating people directly affected by tsunami. And so till date, we have so far provided shelter for 420 elders. And through our various efforts, in the community, we were able to send back about 78 elders back to the families through counseling and other things. And over a period of time, a lot of elders also they lost their lives because of aging and aging. And as of now, we have about 79. The capacity is for 100, but we have about 79 elders now, consisting of both active and assisted elderly and destitute elderly. So though the assistive active elderly were taking very good care of the destitute and the bedridden abundantly, but still it was a challenge because neither they were trained, neither were they were equipped to take care of this and that's where the need for a palliative care was felt in. And with the gracious support of TEVA, we were able to initiate this project about 2 years back. And finally, we came up with this building, which was inaugurated this morning. And we greatly appreciate TEVA's for this wonderful support, because now about 10 elderly we have a capacity for 10 elderly. Bedridden patients, 24 hours care is provided by professionals. And it has been a great source of help, and we're able to see even recovery, because earlier when people become bedridden, that we used to start counting the days for the demise. But now things have changed. Now there's a lot of hope for people who have gone to the last stages and come back because of the reassurance and of the timely care and support provided by this thing. So this is a great opportunity for us to showcase to the world that what is being done here. And I greatly appreciate each and everyone who is present here. There's going to be a consultative meeting, and once again I render a warm welcome to each one of you. Thank you very much, and enjoy the day.
Thank you, Edwin, for giving this overview, how this elders village was built and why it was built. So in this village, we have kind of active, assisted, and destitute elders which are living here and making their lives smooth, active, and healthy. With this context, I will request our Helpage CEO, Mr. Rohit Prasad, to come in and give the context of today's dialogue for about community palliative care. Rohit.
Thank you, Ritu and Edwin. First of all, on behalf of Helpage India, I would like to welcome all of you, those who are present today with us in person, and also those who are online. And I can see Dr. Rajagopal. Sir, namaste and regards to you. And Dr. Shushma Bhatnagar, who is also joining us and will be participating in the discussions as we go along. Welcome, both of you. We are convening this discussion or an event in participation with Teva Pharmaceutical India, and we are absolutely delighted that their senior management team, including the CEO, has taken out time to join us today, visit us in this Tamarikulam Elders Village, as Dr. Ritu and Edwin introduced. At Helpage, we work with the disadvantaged communities, and that's our mission. We try to bring healthcare, livelihoods, and other support to the disadvantaged elders. And this we try and do through partnerships with multi-stakeholders, including the government, the corporate sector, and the social sector. And if you see in our communities, we have elders. They are there in our homes, they are there in the community, they are there in our country. The number of elders, they are rising because of the demographic shifts, and they will continue to play an important role in our future. They have contributed immensely to us, the country, and they will continue to do so. But as we know, many of the age-related aspects come into the play. So if you look at all the elders that are there in our country, many of them are very active, and we can see around us, who continue to play an active role in our homes, in our communities, in many different ways. But over time, with age, some of them also need support. They need some kind of assistance, and therefore we are all there to provide them. But you also have a segment of the elders who will need greater support, or a support that is more intensive, and these are for various reasons. And this often comes up in our work. The current home that where we are, we call it the Elders Village. This is a home where people who have faced isolation due to unfortunate situations, but they face isolation, they face neglect, and it is our privilege, and with all humility, we try and provide them support. But you also have elders, we see elders in mobile health units when we go and serve them, and we find a lot of their needs, health needs are something that we try and address. So if you look around, there will be elders in our villages, in our communities, in our cities, and they will require different kind of support. Some of them, as I mentioned, are active, but some of them may require support. And some of them, and this is the discussion for today, that why a discussion on palliative care. So I just want to take a moment to bring out the relevance and importance of this area. So as I mentioned, some of them, many it's across age groups, but age is a risk factor. So many of them may face serious illnesses. And it's a very important aspect for us to recognize that these serious illnesses, when somebody is diagnosed with, it's a life altering situation, not just for the person, but also for the family and the community. But these serious situations, so the serious illnesses, require a lot of different response. And often we associate this with cancer. And cancer is, of course, a very, very major contributor to this. But with over time, we have seen this, that it is also beyond cancer. So we see it in neuro, respiratory, and many other conditions where these serious illnesses will play a role. But another important dimension, and this is possibly one of the main reasons why the caregiving for palliative care is such an important area, is that people will live longer with serious illnesses. And it's a good thing that the medical science is bringing support to life extending areas. But it also means that somebody with serious illnesses may live a longer phase of life. And therefore, as a society, we need to see how we can bring support to that. What is the current situation? And statistics suggest that almost 7 to 8 million elders or a population lives with serious illnesses. And almost 80 to 90%, and the numbers may vary, but 80 to 90% of them don't get the support that they need. So the need is growing, the gap is huge, and therefore a coordinated and comprehensive response, not only at the policy level, but also at the program level, is required. And this would involve partnership between social sector, the medical system, the family system, and also they require new models of thinking in terms of innovation in both community and programs. So today morning, as Edwin was mentioning, we inaugurated a center, a Karuna Compassion Center, that has been so generously, and with a lot of gratitude, we thank them for helping us set up this center within the TEV home, along with
Wi-Fi.
Along with a community outreach. Yeah. I think we have. So at the national level, we have a palliative care policy in place. And the government of India and the health system, as well as the social justice system, has recognized palliative care as an important area for us to take up. But today, in this dialogue, and the reason we are convening this dialogue is that we all feel that this area deserves much more greater attention given the scale and the response it needs. And there's a very powerful line that has been said often in context of palliative care, that pain is inevitable, but suffering is not and need not be. I'll just repeat that. Pain is inevitable. It will happen because of various reasons of serious illnesses, but suffering is not. Suffering is something that we can all work towards alleviating and ensuring a life of dignity, care, compassion, and love. And truly, we believe in our work that this is God's own work for those who are struggling. They live at the margin, and with humanity and compassion, we can come and make a difference. So, this multi stakeholder dialogue is being held with this goal in mind. We will, of course, begin with an opening session. And in that opening session, we have distinguished experts joining us, and I'll be introducing them. And we'll try and cover multiple dimensions around this question around how to design better systems for palliative care. And these questions can be around the scope, in terms of what palliative care covers. It can be in terms of timing. When should palliative care be introduced? Before, after, along with medical care. It's also a question about integration into health systems because it cannot be sitting in isolation, and also about community based care and other models that we need to develop. So, let me begin today by welcoming our keynote speakers, our distinguished speakers. And I would like to now welcome Professor Rajagopal and Dr. Shushma, who are on the screen. But I will also like to call on stage Ms. Pooja. She is the CEO of Teva Pharmaceutical India. And Mr. Sundarajan, I think he's not here, but Pooja, he's on the way. But Pooja, would you like to take a seat? And so we'll begin. We'll have Mr. Sundarajan joining us shortly. But we'll begin by hearing from Mr. Professor Rajagopal, Dr. Rajagopal, whom I have immense regard and respect for, along with the entire country, absolutely cherishes his journey of advocating for palliative care across many years. He's a true pioneer and advocate for mainstreaming palliative care in the country. Dr. Rajagopal, has been advancing palliative care and access to pain and relief for many years. His advocacy has transformed both policy and practice across India. His contributions have earned him global recognition, including major international honors and India's Padam Shri. But Dr. Rajagopal, I have deep admiration for you, but I would like to take this opportunity to mention to everybody that his book, Walking with the Weary, if you have not read it, you must. And it is a book that completely not only talks about his journey in palliative care, but introduces you to palliative care and the concept and the ethos in an absolutely sensitive way, and you'll have deep appreciation for that. So, Professor Rajagopal, we would like to hear from you on the policy and the national framework. You are best positioned to outline that given your long years. So we would like to hear from you that where is the country right now in terms of its palliative care system journey, and what's your input as we look at initiating this dialogue. So over to you, Professor Rajagopal.
Sir, thank you. Thank you very much for your very generous words. And hello to my colleagues, the fellow panelists, Dr. Sushma and Dr. Pooja. Good afternoon to all the participants. I am given 10 minutes. I'll bear that in mind. The first point that I want to say, let us make this very clear. We are not talking about treatment of diseases. We are talking about health. Health, let us remind ourselves, is not only absence of disease or infirmity, but physical, social, and mental well-being. Physical, social, and mental well-being. If we treat pain and let the person starve, he will, leave alone all other problems, he will not take your tablets 3 times a day after food because he may get food once a day. And the majority of the elderly in India, vast majority, are women, just because women tend to live longer, at least by 2.5 years more than men. It is in this context that we should see the problem, see the government plans, and when we implement, let us make sure that we understand it as our responsibility to get something done about it, including a leaking roof, because they have not been able to thatch the roof. Do you mean that doctors and nurses have to go and rethatch the roof? We don't. We only open the door for the community to come in. There cannot be any community in this world where there are no compassionate people. We healthcare people have closed and bolted our doors with a security guard inside, making sure that the community doesn't come. Open the door, empower them, and they will be there. They are there in Delhi, they are there in Kerala, they are there in Uganda, they are there in Brazil. Maybe the healthcare system of the high-income countries may be a little harder because of the medico-legal climate, but many places in India have successfully demonstrated the role of the community. But that's not my subject. I know. Apologies. I am asked to talk about the government programs and policies and frameworks. That's where we have a huge gap. We have programs and policies without an effective implementation framework. I'll tell you why I say that. But the problem, unfortunately, is huge and growing. Let me share just 5 slides. The numbers will vary in different data sheets. Depends on how you define many things. In India's census is already 14 years old. And that shows a much smaller number, but it's also what you consider abandonment. This report was really troubling. It says 70% of Indian seniors are being abandoned by their children. 70%, my good God. The abandonment may not be total, but very often is. And something else that is very disturbing is that the problem is worse than any other state in Kerala, Punjab, and Goa. The 3 states with better education than many parts of the country and more wealth. They are not the poorest. And this report also points out, I have given the link there. Anybody is welcome to it. Ritu, you are welcome to share the presentation with all the participants so that they can access the link if they want to. They also show that the really poorer states are much better off. The joint family structure and possibly a part of the Indian culture that persists is retaining humanity. Let us be conscious of this. Now, specifically about the government programs. I think, I was painting a very grim picture, but I think we are on the steep part of the growth curve. We have these 2 documents. One is the National Program for Palliative Care, formed in 2012. The whole program, the whole report, the National Program document is not on the government website, but I can give it to you. It involves palliative care component at all 3 levels of care: tertiary, secondary, and primary, which is important. You talk about community and go to the primary level, and you create a lack of newly or more of newly qualified doctors every year who have not seen palliative care in their medical colleges. Similarly for nurses. So that's important. Also, the National Health Policy of 2017 includes palliative care at the primary level. Now, following this, these were in the COVID years, something exciting happened. The National Health System Resource Center of India, NHSRC, which is a body under the Ministry of Health, took it up. Now, they created training material, PowerPoint documents, Word documents, PowerPoint documents, and videos, trigger videos, 50 videos, and started training. They trained 5 categories of healthcare professionals, including doctors and ashas and all levels in between. They first trained national level trainers who could go out and give that primary care training to others. And after that, they did state level leadership programs. They trained healthcare providers selected from all states. There were multiple sessions, each for a few states each. So this was not one of those paper tigers that it seemed at that time, something that was being implemented. It seemed. Unfortunately, after the COVID years, progress has not happened. It is yet to happen. Initially, it was thought that the Ministry of Health, the Government of India, will continue to support state governments in initiating this and running this, at least the building states. But then something happened and it did not happen. But these policies are there. Though the implementation framework for the NPPC created by the WHO India was not officially accepted, it is there. These are implementable. If national level leaders like Dr. Sushma find it possible to work on this, certainly many of us will collaborate with you. You are at the seat of power, and maybe much can be done. The NHSRC documents are given in this link. Again, please take a look at them. It will be informative. The one thing very interesting, I am sure HelpAge India will be very interested in this, is that initial discussions made it clear that palliative care and elder care are not two things to go divergently, they need to converge. So the program was renamed Palliative Care and Geriatric Care, not in the policy document, but in the program conducted by NHSRC for state level and national level trainers. So the modules are for both geriatric care and palliative care combined together, because I believe honestly that the elder care without palliative care is unfair. You are helping, giving them promotive care, but then when they are seriously ill, you either abandon them or push them to intensive care units. Equally encouragingly, from 2019 and 2022, undergraduate medical and nursing curricula include palliative care. Again, a proper implementation framework is lacking, but wherever doctors and nurses are interested, we are conducting faculty development programs for them so that even if they don't have a palliative care unit, they can implement this. If we take it as 1985 is the year when palliative care took birth in India with Shanti Avedana Sadan, created by Dr. Lucito D'Souza. Then 40 years have passed. Palliative care has grown. At least if you calculate by access to pain relief, from next to nothing in 1985, it has grown to about 4% by 2025. 0 to 2%, 4% is not a great growth, you may say, but in our country, 4% people are a lot of people. Well, but to all the young participants, I confess my personal feeling that our generation has failed in improving the situation reasonably. We have been successful only in making a beginning. But because the policy ends are there, and because it is in the undergraduate curricula, now it is the ripe time for a steep upward growth. I believe if, as your title suggests, the implementation frameworks are put into place, in most states, things can move forward fast because it is not expensive. As the Lancet Commission report of 2017 says, for low middle income countries like ours, the cost of an essential package of palliative care is only 0.6% of the cost of universal health coverage. Cost is not the issue. The will is the issue. Will we continue to abandon them and pretend that we are a cultured society when this is happening? Even if you do not accept the 70% or accept their definition of abandonment, still the growth is huge. Thank you, sir. Thank you, HelpAge India. Thank you for taking this step forward. Thank you for giving me an opportunity also. And I am sure with your initiative and collaborative action, we can make substantial progress. Thank you very much.
Thank you, Professor Rajagopal. I don't think I could have asked for a more appropriate start to this dialogue. And I was just reflecting on few points that you mentioned, and interestingly and very provocatively, and I think factually correct, that you started with the case for the elders being abandoned. We can debate on whether it's 70% or 50%, but directionally, I think this is a matter that we have to all worry about. But true to your nature and and the long years of experience and the wisdom that you have. You very, perfectly assessed the current state of palliative care in our country, and you mentioned about the framework being in there, the policy being there, but the progress on that is something that we all have to work for. And you almost called for action on that, and I think we all agree with that. I think the second aspect that you rightly and you know captured is that the elder care without palliative care is not something that is something that we should work for. It must be embedded and integrated into the elder care framework, and some of that thinking has already happened. But I think you ended on a point where you said that we are poised at a point where we can go for a big change or a very accelerated change in enabling the palliative care system in the country. And I think that's a very positive frame that we have. And you also talked about the opportunity, sir. So thank you very much. I think that sets the frame for our dialogue as we go along. Now I would like to, and meanwhile, Sundarajan has also joined us. So thank you, sir, for joining. And as we continue the dialogue, I think the next, it's a very important aspect that how can multiple stakeholders play a role in this? And Professor Rajagopal mentioned about some, and we look at the corporate sector uh, along with the various different sectors, including the government and the social sector, as very important players in the system of enabling change, building our future, and what role they can play. I mentioned about Teva Pharma India as an important part of their corporate social responsibility, setting up a compassionate center, Karuna Center at this home, along with the various other work that they do under CSR. Now, I would like to introduce Ms. Pooja Singh. Pooja Singh is the head of Teva India and Global Business Services. She is the vice president, head of India and as the Global Business Services, as I mentioned. She is somebody who's a transformational leader. She's deep experience in building and scaling global business services centers for very leading organizations, including Google and the Access Group in her prior roles. She has driven enterprise-wide change through data-led strategy, operational excellence, and uncompromised delivery. Um, a business leader par excellence, and her business acumen is something that we all heard of. But I would also like to share that in my interactions with her, and the way she's shaping the organization, and in her thinking, she's comes across somebody who's very socially awakened leader. She thinks from the heart, very compassionate in her thinking, and some of the care for the elderly is something that she deeply thinks about and resonates with. So it's absolutely our privilege, Pooja, that you are here with us today and to participate in this dialogue. And we would very much like to hear from you how Teva Pharma India, as well as you and the leadership team, is thinking about the role corporates and under CSR and more broadly can play a role in this very important area of development of palliative care system in the country. So I welcome you, Pooja, to say a few words here. What?
I believe it's like mic on your phone. Can you? No? Okay. Hi. I don't like holding mic in my hand. Anyway, well, thank you so much for this very, impressive introduction, Rohit. Ever since I have joined, there are defining moments in one's career and one's life. I have experienced many defining moments with Teva in my journey of the last 11 months. I've been fortunate to have represented the organization and truly humbled to have represented the organization in multiple similar forums where, we continue to demonstrate, the passion that we have for care. We've always tried to center our efforts or CSR initiatives in elevating the communities that we operate in or the societies that we operate in. We've carefully selected projects ever since 2020. We've started making a concentrated effort around care. And if you really look at our mission statement, TEWA is all about we are all in for better health. So this sits right, resonates right with our mission statement as an organization. Ever since 2020, we've selected meaningful CSR projects centered around care, be it mental health, be it pediatric care, geriatric care, or palliative care. Our engagement with HelpAge India is not new. We partnered with HelpAge India for creating a meaningful project which continues to be the bedrock of all great learnings and so it just really gave us a clear understanding of what does it take to build a meaningful project in the area of palliative care. So we continue to have that or use that project as our guiding light, for building subsequent or similar projects, in other states. That project is called Karunaya in Tamil Nadu. We are very, very proud of it. Building on to our ambition of supporting care and keeping care as the center of our, carefully selected initiatives. We also joined hands with the state of, Goa, and 2 months ago, we launched, with the Goa Medical College, we launched an OPD for palliative care. And this was inaugurated by Honorable, Health Minister Vishwajit Raneji. It was also another very humbling and yet defining moment for my career. We will continue to keep, I understand that, we are just, our contributions may appear small steps in this direction. Rohit spoke about some numbers, and I'll talk about those numbers again, that the requirement for palliative care is upwards of 7 million in India, and the care is only available to less than 4%, which means we have to continuously keep building our efforts. And we truly believe that if everybody comes together to create an ecosystem, these small efforts will result into having care and compassion, or an ecosystem where there is dignity in care, where there is a fundamental shift in the way we think about care, and there will be care available to more people, broadly speaking. And it will not just be restricted to some of the projects that we are all doing. With that, I'm very happy to announce that earlier today, we also signed an MOU for yet another initiative, which is compassion in action. I really like the tagline, which is compassion in action. This is going to be palliative care for Karnataka government, and we are also going to be doing this with HelpAge India. So we are truly thankful for the partnership, all along. Rohit, you asked me a question about the corporate view on care. I would say, I can answer it in a few different ways, but the direct impact a corporate can make in ensuring that people are more aware is, through having right frameworks and right policies for its people. And I want to tell you that TEWA is already ahead of, many other organizations in terms of having a framework where there is already appreciation for, or there is sensitization in the system, for people to acknowledge that if somebody has any caregiving need at home, it is not taken against them, and it's not becoming a deterrent in their promotion cycles or their increments and thereof. We also have enough sensitivity in the system built to respect the bereavement leave, and we give people the time that they need to heal from their own losses and come back, when the clock is reset. So I would say, from a more direct impact, the policies have to start talking about care as a concept. We also provide people volunteering opportunities. So we not just identify critical projects or these strategic projects, but we also try and give volunteering opportunities to our people. They can select any project of their choice, and they can pick up the hours that they want, which is a part of their our framework. So outside the remit of making policies that are supporting care as a concept, I also believe that we need to broaden the horizon a little bit, or broaden the term or the stigma attached to the term palliative care, and moving it away from just end of life to saying maybe it is about creating a compassionate companion. Maybe it is about people having to go and read a book for these people who are just wanting nothing but an engagement opportunity with you. Corporates can also come forward to help lift the administrative responsibility of NGOs and support them in the complex regulatory framework of either these pain medicines or morphine, and administration of other complex regulatory requirements of these pain medicines. We can also create these social media hashtags to educate more people about what care really means, and which is outside the remit of just end of life and the works. So I would say it is about time that we all start broadening our repertoire or horizons and start looking at care more differently. And I understand there is a lot of push from the policy side, and the two needs to come together. There has to be a perfect marriage of how we think and how the government kind of guides us to execute. But as running an organization and as a citizen, I think it is time that we start shaking our paradigm also a little bit, to start thinking about care more broadly, have more dignity in how we see care. And with that, thank you so much. I'm very excited about our next project, which is compassion in action. I would see how that pans out, but this visit has been truly a very, very humbling experience for us. Like I said, there are defining moments. I've experienced many in the last 11 months. The peace and serenity of this village is, kind of taken me by a lot of, inspiration to say there is so much more that we can do and contribute. Thank you so much for bringing this together, and thank you.
Thank you so much, Pooja, for sharing your thoughts and reflections and the role corporate sector can play in this area. I think you mentioned small contribution. I would say a very meaningful contribution, especially in an area that is starving for attention. And all efforts are very meaningful efforts, and Teva's contribution in this area is really appreciated. You also talked about how care, the thinking around care itself needs to be go under a paradigm shift. And I think the compassion in care is a point that you highlighted, and I think that's a very important aspect for us to think about. And the way many corporates in our experience are now embracing elder care, and this is an area that requires more attention under CSR. And I would like to compliment Teva for taking up elder care as part of their CSR efforts. And this is something that we hope, along with the youth and women and other sections of the society that need attention, I think the elder care is also an important area for. So thank you very much for sharing your thoughts. Now, I would like to, in the spirit of the dialogue, we started with the overall overarching government policy framework. We heard from a very important stakeholder, the corporate and the organizations, the role they can play. Now I go to Dr. and Professor Shushma Bhatnagar. We have her right from the beginning. Thank you so much, Doctor, for joining us today. We are truly grateful that you took out time to join us. Dr. Shushma Bhatnagar is a nationally and internationally acclaimed leader in cancer pain management, palliative and supportive care, and onco anesthesia, with over 3 decades of impactful teaching, research, and clinical innovation. She has formerly held senior leadership roles at AIMS Delhi, shaping education, policy, and clinical practice in palliative medicine, and has earned prestigious global and regional honors. She's truly one of the leading lights in palliative care, a true practitioner who has worked in the public health system or the government system, and as well as has has exposure in the private healthcare system. So nobody who's better positioned to talk about how palliative care can be integrated into different levels of care. And Dr. Shushma Bhatnagar, we look forward to hearing your views on how the healthcare system and its integration with the palliative care system needs to change. So over to you, Dr. Shushma.
Thank you very much for the generous introduction. Thanks a lot. I'm really honored to be over here. Actually, after hearing Dr. Raj Gopal about the government policies and then about the corporate responsibilities from Pooja, I think there is a lot of things I would like to say now. Because, when I worked for 3 decades at AIMS and when I joined just less than a year back, corporate sector, I realized there is a huge deficiency and there is a huge lot of work we have to do because we talk that every patient, those who are suffering with any chronic debilitating condition, there are so many patients suffering with chronic debilitating condition. We can work in one hospital, then another hospital, and then every hospital, but we have to work at different levels. And this is a very appropriate topic that we have to work at a different level. But my experience says that we have to work a lot in the medical community. We have to work a lot with the doctors and nurses because they are the one who are looking after all these patients, and they should know that what are the different levels of care which a patient needs who is suffering with any debilitating condition. So I would like to share that what exactly Dr. Raj has told you what government has done. I will brief you that what as a 6 years I was president of Indian Association of Palliative Care. So I have made few slides and right now updated with the current president that what exactly as a national organization Indian Association of Palliative Care is doing and what we have done with the AIMS and other projects, so that you will have an idea that how much we have developed and how much we have to do. The figure of less than 4% is not getting up because we have not integrated in our medical system clearly. We have not integrated in our medical system amongst our doctors very honestly, because our doctors, they still have a belief that palliative care is something which basically does not have any existence in the journey of a patient. So this I'm telling with my own experience in the present setup, and the last setup also struggled a lot in government setup, established a system, and now in the corporate sector I have realized that doctors will have to teach doctors a lot, as well as the community, as well as the public, as well as the people, those who are suffering, because even the people, those who are suffering, they keep thinking that only treatment or only helping a patient is just getting treatment, and getting treatment of any kind, whether it is chemotherapy or immunotherapy or ventilator or ICU. So we have to teach at different levels. So what exactly we have done and how much we can help all these patients. I will tell you some very quickly. I will go through my slides. There are a lot of photographs, so I will go fast. See, this system is already embedded in our system because this, Ashoka King was not a doctor. He was not a nurse. But he has developed some kind of a hospice kind of an institution for the patient, those who are suffering in the Gangetic Plain. So it was there in our system, and what we have realized that this is there in our system as when we go to the families and various houses, we still know that people, they are looking after their elderly, they are looking after their the neighborhood, those who are suffering. And that is what the HelpAge India also has a feeling, that we have to take care of the people, those who are suffering, whether it is elderly or whether it is the patient, those who are suffering with any kind of illness. So this is there already there in our system. And this is a figure which we have to be very, very see closely, that all these people, those who are suffering with any chronic illness, they are going to die. And India is still not the best place of death. India is still on the 59th position when we compared it with 80 countries. So India still is not a place to die, give a best death to the patient. Why this is happening? Because we have not embedded palliative care completely in the system right from the beginning. Right from the diagnosis till the treatment, when people are dying, we have not embedded this. So where we can do and how much we can do and how much we can create, take a help of already existing system. So a lot of people are working, government is working, a lot of stalwarts and the leaders of palliative care, they are working, everyone is working in all these four pillars: capacity building, drug availability. As Dr. Pooja said, that drug availability, it is such a huge problem. The biggest hospital, corporate hospital, when they cannot provide opioids to their patient, how can we think that this will be available for whole of the country? So this is a very important problem which we have to highlight, that morphine, which is the cheapest drug available, but it is available only where the places where somebody has worked hard and made it available in that particular hospital, but it is not available. It should be uniform in all the hospitals, because all the hospitals people are suffering. So we have to work, and everybody's work is hard, but we have to work in this area a lot. Education, I have already told, I'm telling you, there is a huge gap in the knowledge of doctors and nurses. They don't know that how palliative care should be integrated in the continuum of care. IAPC is doing a lot with the Project Kiran. They have taught doctors, they are teaching, they are doing dedicated courses on volunteers. So if a community volunteer wants to work, what they can do, how much they can do, and what they should not do, there is a dedicated course for pharmacists, for physiotherapists, and for the doctors, for psycho-oncology. The biggest problem, our doctors, they don't know how to communicate when patient is dying, but they cannot do anything to cure. They know how to talk to the patient, that I am doing something, and we are trying our level best, but I don't know. And when patient is dying, then they say, sorry, I couldn't help it, and the treatment has not worked. But they don't know how to explain a patient when patient is dying, that there is something we can do, but we will not do something to cure, but we can do something to care for you so that you can die. So there are dedicated courses on psychosocial this thing. At intermediate level, a lot of courses are going on all over the country. I will send these slides. I will keep these slides. So all the doctors and nurses, these courses are for doctors and nurses. We can use these slides. There is a very good thing which we have started, that is lecture series in the morning from 6:30 to 7:30 on Monday morning. So anyone who wants to join these lecture series, and this we have started in COVID and is still going on, and the standard of the teaching, from basics to the highest standard, this is a beautiful lecture series if somebody wants to start. Specialist palliative care, again, we are doing very poor. We are doing absolutely not at the par what we should have done. In 2012, Medical Council of India has recognized MD palliative medicine. But can you believe it? It is 2026 we are entering. We could start MD palliative medicine only in the 8 hospitals of this country. Then National Board of Examination, they have started DNB palliative medicine, and we could at least from 2021 till 2026, we could start in 9 hospitals. So this is at least better, but the huge country of 1.4 billion population, I don't think that these doctors will be sufficient. There are many things which we have to do at various levels. And the biggest thing which I still feel. When I was working in AIMS and working with emergency doctors, there was a huge gap of understanding that how much a palliative care thought process, how much a palliative care basic understanding can help to a patient. And this is again I see in the corporate sector. They don't even want to talk about palliative care because they think that it is only for dying patient. And my patient is not dying, so I should get treatment. So all these places we can start. Here, I want to say that Academy of Palliative Medicine has worked very hard, and I am very happy to say that we have started in Academy of Palliative Medicine a joint course on geriatrics and palliative care, and this first course is going to complete very soon, and it has got a very it has become such a popular course, and I am hopeful that when a doctor of palliative medicine will understand that geriatric medicine is as Dr. Rajgopal has clearly said that they have to come together, and this course is other courses also we have started. Then this is a very important course which we started in CTC, where we made sure in 84 hospitals all over the country palliative care program is started. But this was not enough because we have not reached to the ground level. Then we started through ICMR, we started a project and created hub and spoke model, and 90 districts of north part of India, we have created dedicated palliative care program in 90 districts. Our aim was in 100 districts, but 10 districts we couldn't start. In 90 districts, we have started this hub and spoke model, and these are the various photographs of. So we have reached to the valleys and we have reached to the mountains and everywhere. So this is my last slide, that at every level, what the purpose of showing the slides, that there are models available. A lot of people are working very hard at various levels, from doctors, nurses, volunteers, physiotherapists, psycho-oncologists. Everyone is working hard, but we have to streamline the government policies, government programs, and the programs which any organization like IAPC or Palliative India is doing. We have to come together to make so that we don't have to replicate, but we can make a sustainable program which will go on. And everywhere, I feel very bad when I work in this, when I see the corporate sectors of this country, that every patient has to die in ICU. This is what the corporate sector's policy is. But they have to learn that when patient is dying, when patient cannot be cured, they can die peacefully at home. They can die peacefully in the lap of their loved one. And this is definitely changing. And within no time, we have changed in this hospital. But how we can change in other sectors? How can we make essential medications available? How can we change the mindset of doctors and nurses? There is a huge work which we have to do. And I would like to congratulate Helpage India that they have taken this task today, and they at least we can whosoever is listening, they will have an understanding that every level there is a gap, and we have to come together and make it important and essential parts of a journey of any medical disease, or any patient who's suffering with end stage heart disease or kidney disease or lung disease or cancer. Thank you very much.
Thank you so much, Dr. Shushma Bhatnagar, for that very insightful as well as very hopeful, inputs. Because I think you said some few things which were very important. And one, of course, you mentioned about how the medical fraternity, the sensitization and the awareness and understanding has to also improve significantly. And you called out that, and you said that these are changes that are very important. If we recognize that the medical system must collaborate with the social and the family system, but we also recognize that the medical system has a very important role to play, and that change there needs to happen. You mentioned about the IAPC, Indian Association, as well as the Academy, and some wonderful efforts are going on in that direction. And thank you for sharing us with the different efforts that are on. And we hope to collaborate with the Academy, the association, and all the different efforts that are being done. So before I go to my next speaker, I know Ms. Pooja Singh and the team from TEVA have to leave. They have a flight to catch in the evening, and we were hoping to wrap up, but the discussion took a little longer. But thank you so much, Pooja, for joining us today. We will continue the dialogue, and we'll update you later on some of the conversations that come up. We would just like to give you a small token of appreciation. So while the three speakers, the very distinguished speakers who have highlighted the national policy framework, we talked about the role of multi-stakeholders, including corporates, and Dr. Shushma Bhatnagar in her talk gave us a very insightful view of the different efforts that are happening. But all this is very important and will become successful if it comes around to the district level, and some of the changes that we envisage making forward also comes together at the district level. And I am delighted that Mr. Sundarajan, J. Sundarajan, has taken out time to join us, sir. Welcome, sir. He's the Revenue Divisional Officer of Cuddalore with extensive experience in district administration and public service delivery. In his role, he oversees key functions related to governance, coordination across departments, and implementation of welfare and development programs at the sub-district level. He brings valuable insights on district level convergence, community engagement, and translating policy into action for inclusive service delivery. And all these aspects that I mentioned, we know that it's a national priority for governments to make action happen at the sub-district level. A lot of the delivery and implementation and convergence happens at the sub-district and district level, and that's the focus of the government. So we look forward to hearing from you your thoughts on how palliative care can find greater momentum at the district level. So welcome you to share your experience with us.
எடுத்து வரல, ஜஸ்ட் ஸ்போக்கன் டு ரெண்டு நாளைக்கு முன்னாடி தான் வந்து சொன்னாங்க. ஜஸ்ட் இது தெரிஞ்சதுன்னா ஒரு நரேட்டிவாக ஒரு ஸ்டோரியாக எடுத்து வந்துருக்கலாம். ஜஸ்ட் ஓகே, நான் தமிழ்லேயே கொஞ்சம் பேசலாம்னு நினைக்கிறேன். எனக்கு தமிழ் புரியும் நினைக்கிறேன். ஓகே, லோக்கல் லாங்குவேஜும் எனக்கு அதுதான். ஸோ ஃபர்ஸ்ட் ஆஃப் ஆல் இந்த தாமரைக்குளம் எல்டர்ஸ் வில்லேஜஸ்க்கு ஒரு பெரிய பாராட்டுக்கள். உங்களுக்கு ஒரு பெரிய கிரேட் அப்ளாஸ். ஜஸ்ட் இந்த வேர்ல்டர்ஸ் வந்து நம்ம மெயின்டைன் பண்ணுறது வந்து பெரிய விஷயம். குழந்தைகளை வந்து பராமரிக்கிற மாதிரி தான் அவங்களுக்கு. இட்ஸ் கம் டு ஏஜ் ஆஃப் அபோவ் 60. ஆல் ஆர் ஏஜ் அபவுட் பிகம் ஏ சைல்ட்ஹுட். அவங்களெல்லாம் நம்ம வந்து பராமரிக்கணுன்ற அந்த ஆஸ்பெக்டில் கொண்டு வர அந்த தாட் வந்தது. அவங்க எல்லாம் பார்த்தால சில இதில் நம்ம பார்த்தோம்னா இப்பயே நம்ம நடக்கிற நிகழ்ச்சிகள்லாம் பார்த்தீங்கன்னா, அரசியலில் பார்த்தபடி ஒருத்தர் அப்பான்றாங்க, அம்மான்றாங்க. ஏற்கனவே அம்மான்னு சொன்னாலே தெரியும் நம்ம இதில் அரசியலில் பார்க்கும்போது. இப்போ நம்ம இதில் பார்த்தீங்கன்னா, நம்ம இதில் ஓவரால் 60 மேலே இருக்கிற ஓல்டேஜஸ்லாம் என்ன கூப்பிடுவீங்க நீங்களே? தாத்தான்னு கூப்பிடுவோம், அம்மா பாட்டின்னு கூப்பிடுவோம், அப்பான்னு கூப்பிடுவோம், அம்மான்னு கூப்பிடுவோம், மாமான்னு கூப்பிடுவோம். ஜஸ்ட் நம்ம அவங்ககிட்ட பழகிற விதங்கள், அதேமாதிரி நம்ம அவங்களுக்கு என்னென்ன வகையான நோய்கள்ன்றதை கண்டறிஞ்சு அவங்களுக்கு ஒரு மருத்துவத்தை கொடுக்குறோன்றதை வந்து சொல்லும்போது அது வந்து அவங்களோட கேர் எடுக்கிறோம் பாருங்க. ஜஸ்ட் அது பெரிய இது ஒரு வரப்பிரசாதம். அதாவது அவங்களுக்கு ஒரு மறுவாழ்வு கொடுக்குறோம். அது வந்து எல்லாராலையும் வந்து அந்த ஒரு இது வந்துடாது. சகிப்புத்தன்மை வேணும் எல்லாத்துக்கும். நர்சிங் கேரில் இருக்கிறவங்களுக்கு தான் அந்த இது வரும். அதையும் இப்போ நம்ம பார்க்குறவங்களுக்கு எல்லாருக்குமே நம்ம இந்த ஹெல்பேஜ் இந்தியா இதில் இருக்க இந்த கம்யூனிட்டி வில்லேஜில் இருக்கிறவங்க எல்லாருக்குமே அந்த ஒரு பொறுப்பு இருக்குது. நம்ம ஒரு டைம் இதுக்கு ஸ்பெண்ட் பண்ணி நம்ம வந்து பார்க்கணும். டைம் லிமிட்டோட இருப்போம். இந்த டைம் தான் சாப்பிடணும். இப்போ வென்னவர் இந்த எப்போ விளையாடணுமோ எப்போ விளையாட போகிறோம், எப்போ சாப்பிடணுமோ சாப்பிட போகிறோம். அதேமாதிரி நீங்கள் இந்த தாமரை எல்டர் வில்லேஜில் அந்த இப்போ இவங்களுக்கெல்லாம் பார்த்தீங்கன்னா காலைல சூரிய நமஸ்கார்லாம் ப்ராக்டிஸ் பண்ணுறீங்க. காலைல எழுந்த உடனே என்ன பண்ணணும், அடுத்தது என்ன பண்ணணும், ஒரு ஸ்ட்ராட்டஜி மாதிரி ஒன்று ரெடி பண்ணியிருக்கீங்க. அதுவே அவங்களுக்கு வந்து ஒரு அந்த சுற்றுப்புற சூழல் அமைச்சு கொடுக்குற விதம், அவங்களுக்கு ஒரு அவங்களுடைய ஹெல்த் கேர் எடுத்துக்கிறது, அவங்களுக்கு ஃபுட் அண்ட் இது அதுமாரி வந்து அவங்களுடைய ஃபேமிலியை பார்த்து எப்படி ஒரு நடுத்தரமான ஒரு போகிற இதில் இருக்கிறவங்களோட வந்து அதை கண்டறிஞ்சு ஒரு வில்லேஜ்லேயும் போய் அவங்க யாருன்றதை பார்த்து அதை அவங்கள 2 பேரும் அவங்க அதை பேசி அது வந்து கம்யூனிகேஷன் இருக்குங்களா, கம்யூனிகேஷன் தான் நமக்கு வெரி இம்பார்ட்டன்ஸ். இப்போ நம்ம இங்கே ஒரு 10 பேர் ஆர்கனைஸ் பண்ணோம்னா ஜஸ்ட் கம்யூனிகேஷன் தான். கம்யூனிகேஷன் பிளான் இஸ் வெரி இம்பார்ட்டன்ட். அதில் வந்து நம்ம எல்லாருமே ஹோமேஜ் இந்த ஹெல்ப்புக்கு வந்து நம்ம வந்து ஹெல்ப் பண்ணுறோம். அதுமாரி பார்த்தீங்கன்னா நம்ம கவர்மெண்ட் சைடில் பார்த்தீங்கன்னா இது சார் ஒரு 18th செஞ்சுரியில் நம்ம டாக்டர் பூஜா அவங்க சொன்னது என்ன சொன்னாங்கன்னா 18th செஞ்சுரியிலே இந்த இதெல்லாம் வந்துருச்சு, நோய் தடுப்பு முறைகள்லாம். அது நம்ம வந்து சரியாக பராமரிக்கலை. அது வந்து 18ஆவது நூற்றாண்டு காலத்திலேயே மன்னர் ஆட்சி காலத்திலேயே நோய் பராமரிப்பது எப்படின்றது இப்போ நம்ம வந்து வருமன் காப்பது எப்படின்றத நம்ம தெரிஞ்சிருக்கிறோம். வந்தபின் காப்பது எப்படின்னு தெரிஞ்சிருக்கிறோம். அதுமாரி நம்ம இதில் பார்த்தீங்கன்னா நம்ம கவர்மெண்ட்டில் வந்து எல்லா ஃபெசிலிட்டிஸுமே இருக்குது நமக்கு. இப்போ உதாரணத்துக்கு நம்ம குழந்தை சைல்டு கேர் அப்படி இருக்கும்போது குழந்தை வந்து கல்யாணம் ஆனோன்னு ஒரு பொண்ணு கருவுற்றாலாம் அந்த 30ஆவது நாள்லேருந்து அவங்களுக்கு கேர் எடுத்துக்கிறோம். பார்த்தீங்கன்னா மக்களை தேடி மருத்துவம் அப்படின்ற ஒரு ஸ்கீம் இருக்குது. மக்களை நாடி மருத்துவன்ற போய் பார்த்தீங்கன்னா அங்கே இருக்க ஆஷா ஒர்க்கர்ஸ்லாம் இருக்குது. வில்லேஜ் லெவலில் கீழ் மட்டத்தில் உங்களுக்கு வந்து செவிலியர்லாம் இருக்காங்க. இதெல்லாம் அவங்களுக்கு வந்து என்ன என்எம்எஸ் தான் மேடம், உங்களுக்கு என்எம்எஸ் தானே? ஆஷா ஒர்க்கர்ஸ் இருக்க நல்லா வீட்டில் போய் என்ன பண்ணுவாங்க, யார் இதில் கருவுட்ருக்காங்களோ அவங்களுக்கு வந்து ஒரு மாதத்துலேருந்து 30 நாளைக்கு மேலே என்ன வேணும், 60 நாளைக்கு மேலே என்ன வேணும்னு சொல்லிட்டு அவங்க குழந்தை பிறக்கிற வரைக்கும் வில்லேஜ் ஹெல்த் கேர் ஹெல்த் நர்ஸ் விஹெச்என் வில்லேஜ் ஹெல்த் நர்ஸ்ன்ற ஒரு டீம் இருந்து அவங்க ஃபுல்லாகவே அவங்க இது அவங்களுடைய பதிவு பண்ணிட்டாங்கன்னா அவங்களோட பிறக்கிற வரைக்கும் அவங்க எல்லா 6 மாதம் வரைக்கும் குழந்தை நல்லா வர்ற வரைக்கும் ஊட்டச்சத்துக்கள்லாம் கொடுத்து ஒரு பாதுகாப்பு வசதியை உருவாக்கி இருக்கிறோம். அதுமாரி பார்த்தீங்கன்னா இப்போ ஒரு ஒரு மாதத்துலேயும் செகண்ட் சாட்டர்டே வந்து ஒரு மக்களை தேடி மருத்துவம் அப்படின்ற ஒரு கான்செப்ட் வந்து ஜேடி லெவல் அண்ட் டிடி ஹெல்த் லெவலில் நாங்கள் வில்லேஜ் ஒரு 10 வில்லேஜ் ஆர்கனைஸ் பண்ணி அங்கே இருக்கிறவங்களையும் வந்து அட்மோஸ்ட் கேர் எப்படின்னா உங்களுக்கு எல்லா இடத்துலையுமே எல்லா ஃபெசிலிட்டியும் அங்கே இருக்கும். எங்கன்னா பிளட் ப்ரெஷர்லேருந்து எல்லாம் பிபிலேருந்து சும்மா சாதாரணத்துலேருந்து அப் டு வந்து இசிஜி அண்டு ஈவன் தான் வந்து நம்ம ஆர்ட்ரி இருக்கு இல்லைங்களா, அந்த இதுக்கு கொண்டு வந்து இசிஜிக்கு மேலே நம்ம வந்து ஒரு மேம்படுத்தப்பட்ட மருத்துவம் வந்து உயர்தர சிகிச்சை வந்து ஜிப்மருக்கு அங்கெல்லாம் போகிறதுக்குலாம் ரெஃபர் பண்ணி நம்ம இங்கேயே மல்டி ஸ்பெஷலிஸ்ட் டாக்டர்ஸ்லாம் வர வச்சு வில்லேஜ் லெவல்லே ட்ரீட்மெண்ட் எடுத்து கொடுக்குறோம். அந்த அளவுக்கு நம்ம வந்து இம்பார்ட்டன்ஸ் கேர் எடுத்துக்கிறோம் ஒரு இண்டிவிஜுவலை பற்றியும். அதுமாரி நம்ம இந்த நோய் தடுப்புக்கு உண்டான முயற்சிகளையும் நீங்கள் எடுக்கிறதுல வந்து நாங்களும் வந்து பங்குகளில் பெருமகிழ்ச்சி அடைகிறோம். எங்கள் கவர்மெண்ட் சைடில் நாங்கள் என்னென்ன பண்ணணுன்றது நீங்கள் எங்களுக்கு ஹெல்ப் பண்ணிங்கன்னா கூட எந்தெந்த பாக்கெட் ஆஃப் இதில் வந்து நாங்கள் ஹெல்ப் பண்ணணும்னு சொன்னீங்களா, அதுக்கு நாங்கள் ஹெல்ப் பண்ணுறதுக்கு கடமைப்பட்டிருக்கோம். கண்டிப்பாக உங்களுக்கு பக்கத்துவையாக நாங்கள் கவர்மெண்ட் சார்பாக இருப்போம் தெரிவித்துக்கொண்டு இந்த வாய்ப்பினை நல்கிய அனைத்து நன்றி பாருங்கள். நன்றி நன்றி. தேங்க்யூ சார்.
Thank you so much, Mr. Sundarajan. I picked up three very important points, and I think the aspect of communication was something that you emphasized, and I think at the district level, the role of the ASHA workers and other community workers are extremely important. So with that, I would like to bring to close the opening session, and I again would like to thank Dr. Shushma Bhatnagar, Professor Raja Gopal, Pooja, and Mr. Sundarajan for taking out the time and joining us and sharing their very valuable insights. I think overall, I would just like to say that it's clear that the palliative care, strengthening palliative care, is a very important agenda that is very close to all our hearts. We want to do it. The national policy framework is very much there, but it will take us take a lot of effort, a collective effort to operationalize that. And I think the real challenge is in operationalizing this at scale and in an accelerated way, and we'll all work towards that. So with that, we will close the opening session, and I would like to invite two of my colleagues who will take up the next session, which is the conversation with experts. And I would like to invite Dr. Ritu Rana, who leads our mission health at Helpage India, to the stage. I would also like to invite Mr. Pradeep Chakravarti, who's the Chief Operating Officer looking at our programs nationally. And both Pradeep and Dr. Ritu will co-anchor the next session. Thank you very much. Before I would just like to end with giving our token of appreciation to Mr. Sundarajan. Thank you so much, sir, for taking our time to join us.
Thank you all. So we have closed one session, but still it is a technical session is going on. And so we have discussed about the policy framework. We have talked about what is the cross-sectoral and CSR is doing and what they can be doing, and also why and where is the need and how can this need gap will be filled in by in the training sessions at the across the levels, and the integrated care is required, right? But we also want to discuss further, and for that I would request my colleague Pradeep to give the overview of the next session, what we are going to do, and he'll also invite our esteemed panelist here. Pradeep, over to you.
Good afternoon, ladies and gentlemen. Welcome to the second and the concluding part of the symposium. Some of us were, of course, I'll try to lay the foundation stone for what we would like to go through in the second part of this consultation. But I would just like to go through the base again. Some of us actually went through a field visit to some of Helpage India's community palliative care beneficiaries. And our field visit to some of our beneficiaries have now hopefully given us some glimpse on what Helpage India tries to do in palliative care in old age homes, in hospice settings here, as well as in community settings. We also have a good idea of how to build healthcare, aged care, and livelihoods in community as part of a holistic elder care program. Rohit also talked about a partnership between civil society and private sector and government. And at a national level, he also talked about a palliative care policy in place and the recognition of palliative care as a mark of attention. And the government is, of course, working towards it. And then we had Professor Rajagopal, who talked about the hidden crisis. Mrs. Pooja, of course, she built a bridge between compassionate care and patients, and Dr. Shushma Bhatnagar and Dr. Sundarajan. So now, on this basis, we will try to go deeper into the topic of palliative care, and we are privileged to listen to some of our esteemed speakers and team on team-based care, facility of care continuum, and compassion. So I would just like to introduce some of the panel members. So the first is Dr. Annie, who is the Associate Professor, Department of Anesthesiology, and also the Pain and Palliative Care Head, Mahatma Gandhi Medical College and Research Institute, Puducherry. We have Kavita Vasudevan of Community Medicine, Indira Gandhi Medical College and Research Institute. Dr. Mohan Raja,
Chief Medical Officer, Sanjeevan Palliative Care, Aurobindo Ashram. Dr. Mohan Raj, are you here? Okay. And Dr. Ira Almeida, Project Director Online, she is joining online, Director of the Serena Palliative Care, South Goa, India. So without, we also have Mrs. TMT Porkodi, Deputy Director Health in Kadalur District, and Mrs. Chitra, District Social Welfare Officer. So if you could just please come to the stage. And we will have my colleague Dr. Ritu Rana moderate the discussion on some more detailed aspects of palliative care. I've already given you some of the important discussions, basal discussions that have happened. So over to you, Dr. Ritu.
Thank you, Pradeep. And so this is a detailed discussion, and I'm going straight forward to the discussion. I will request Dr. Annie first. Dr. Annie, so because we have been talking about multi-stakeholder and multidisciplinary approach to the palliative care. So my question to you would be like how the multidisciplinary approach is needed and how it can be coordinated for the palliative care and also in the community. So Dr. Annie, to you.
Thank you. I thank the organizers for giving me this opportunity. In palliative care, it is proven and widely practiced system is the multidisciplinary approach. Why? Because palliative care is not a one-man job. We need doctors, nurses, physiotherapists, psychologists, social workers, everybody to work together to bring in the holistic care. In palliative care, what we tell is holistic approach. You have to see all the aspects of the patient, not just the symptom, like how we follow in our other aspects of medicine, where we only concentrate on the disease, on the symptom, or only see what the disease is and not beyond it. But in palliative care, we need to see the disease and beyond it. We need to see what the patient suffers psychologically, spiritually, and physically, what his caregiver is suffering, and how we can empower them. So social workers play an important role in empowering the family at the community level. The psychologist is needed for all the stress and anxiety, not only for the patient, but also for the relatives. And like we know, the medical team will take care of the patient's medical needs. And the next question was,
how can we coordinate it for the community palliative care?
So even though it is in a multidisciplinary approach, we use in my hospital, we have the hospital palliative care team, which is basically run by myself and another surgeon. And we have our team, which is coordinated by the palliative care physician. So even though it's a multidisciplinary approach, we will have one person who will connect all the stakeholders in handling the patients. Otherwise, there won't be any connectivity. Then everybody will become a referring system. Like how we do, we admit a patient, we take reference from other department. That will not work in palliative care. When we work as a team, we need to stay interconnected under one head.
Thank you. Thank you, Dr. Annie, that we need to be interconnected when we provide the palliative care. And with us, there are two panelists which are joining us online, which one is Dr. Ira Almeida from Goa Palliative Care, and another is Dr. Umesh Bhadani. He is a professor and head of anesthesiology, AIMS Patna. Thank you, both the panelists joining us online and giving us time here. So my next question here is to Dr. Kavita. And Dr. Kavita, I would request you to talk about how to coordinate from facility to home, because facility is something where the patients are taking the care, but when they go to the home, then it is something, a pathway that has to be created. So kindly give us that overview, how it can be created.
Thank you. Firstly, I'd like to thank the organizers for giving us this opportunity to be here. Like she mentioned, when patients come to the hospital, and that's where we provide palliative care services at the facility. And then we need to link them to systems in the community so that this care continues. So in our, what I would like to tell in this few 5 minutes would be to share what we are doing a little bit, so that our experiences, so that, we could learn from that, as well as we can share that what we learn. What we do have a palliative care team in Indira Gandhi Government Medical College. I would like to introduce Dr. Rama Devi. She is the nodal person. She is from Department of Anesthesia, and she runs the palliative care unit. She is the nodal officer for that. The team comprises of members from various departments. So we have a multidisciplinary team functioning at IGMC with inpatient bed facility, wherein the palliative care services are provided. To ensure that this care goes further, we have been involved in the training of health workers, ANM, ASHAs, and medical officers in the government setup who are posted in the primary health center. We have been involved in the training of them with the help of IPM, Calicut, as well as Sanjeevan. We have conducted that. So initially, we did not know what was the burden of palliative care in Puducherry. Now, at least we have some numbers as to say how many patients require palliative care in their respective PHC areas, so that we know this is the burden and this is what we need to cater to. To take it more, I'd just like to quote that, people, all of us would come into 4 categories. People who would have been caregivers in the past, or who are currently giving caregivers, or who would be caregivers in the future, or who would need caregivers in the future. So we just need to think and say, where are we now, or where we would be? So to ensure that this continuum happens, we are trying to build the capacities of students. We have family adoption programs where students are exposed to palliative care. We do electives wherein they have a community-based reach also. They make home visits. We have regular training for interns. So every intern from IGMC is trained in palliative care when they graduate. That much we have tried to ensure in the last 1.5 years. We also have small programs to look at how to operationalize compassionate communities, look at death literacy rates in the community, to look at policy analysis. Those things are going on that are more academic. We also conducted a bereavement workshop, companionship workshop. That's the first in Puducherry, again with the help of IPM and Sanjeevan. And that was a very good stick. So what I feel is, to ensure the continuum from facility to the community, we need to ensure that everyone in that linkage need not be only doctors, need not be only medical. We also need to ensure everyone knows how to care, because it may be them or it may be somebody known to them who may require care. So palliative care should not be restricted only to that particular patient. That when you have a patient with palliative care, then I will train you. It should not be that way. Rather, all of us should be ready to know when we need to provide care. It may be to somebody known to us, or it may be somebody in the community who requires it. Or it may be to impart or train somebody else, somebody who cannot come and get the training. So that linkage is very important. And in Puducherry, luckily because I'm from the government side, I can just say that, yes, there is a system slowly developing wherein patients are getting linked, but we still have a long way to go. Health facilities are well equipped. Most of our medical colleges are very strong. They have good teams. But when it comes to taking it more periphery, we are still taking baby steps, but we are taking steps positively in that direction. So yeah, thank you.
Thank you, Dr. Kavita. Yes, we are taking a baby steps, and the need is to integrate the community and the center at the periphery with the centers which are in the institution. So with that note, we have Dr. Mohan Raja, Senior Medical Officer, Sanjeevani Palliative Care, Aurobindo Ashram, Puducherry. And because we see that palliative care is the community is in the center, community is the focus. We would like to know your view, how that community is the foundation, and how community can take the responsibility of palliative care within their environment, and it is not a specialty driven service, but it's a community driven service.
So thank you everyone for giving me the opportunity. So the one thing I want to say about palliative care is, what we are doing is, palliative care is a life skill. Learn and
keep palliative care as life skill, because only 5 to 10% of us are going to have sudden death. So every other 90% of people are going through some phase of suffering in our life. So the community or everyone should be understanding that palliative care is a life skill, so that whether you volunteer or not or anything, just keep, like Kavita ma'am said, like learn and keep palliative care. The one thing which we usually say about community-based model is Kerala model. People will say, yeah, Kerala is doing great, and other states can't replicate it. But I always believe in people, because us people, especially the South Asians or Indians, we have our compassionate inbuilt within us. But unfortunately, due to various difficulties and those kind of things, we have become a low trust society. We don't trust each other, right? So people will say, oh, we'll exploit each other, those kind of things. So when community gets empowered, like in Pondicherry, like we have trained more, close to around 8,000 people, non-medical people in palliative care. Like in that, people around 200 are currently actively volunteering. So every village, they are taking care of these things. They're setting a foundation. They're not just providing psychosocial support. Many are providing financial support. Many are providing the government policies, those kind of things. Many are asking questions to us, saying like, why this not available, those kind of things. They go to the government and ask, like, can you push this? Because organization or a doctor or a single person can't do a change. Like, if you want to do a change, like the community should come forward. So that's the only change. And until and unless we sensitize community about this, because in India the problem is we accept death, but the suffering we don't accept. We'll say karma, வயசாயிடுச்சு சஃபர் பண்ணி தான் ஆகணும், இது வேற வழியே இல்லை, அப்படிதான் இருக்கணும். ஸோ தோஸ் கைண்ட் ஆஃப் அதுதான் நம்ம ப்ராப்ளமே இருக்கு. ஸோ வி அக்செப்ட் டெத், இறந்துட்டாங்கன்னா இறந்துட்டாங்க அப்படின்னு சொல்லுவோம். பட் அதுக்கு அந்த ஃபேஸ் வந்து வி டோன்ட் அக்செப்ட். சி வி ஆர் நவ் 21st century. We have all medicines, every things in place to decrease the suffering. ஸோ அது இருந்தும் நிறைய இல்லை. ஸோ palliative care will work only when there's a good tertiary system in place, good primary healthcare system and public healthcare system in place. Then only palliative care will work great. Say for example, if a government says, yeah, just open 20 palliative care units in Pondicherry, I don't think the suffering will end, because people are not connected with each other. What I will say is, in community encompasses the NGOs also. So what I will suggest is, the NGOs, everybody should come together and work for a cause rather than work for them. So that's a major goal. So that's I always say is, like, we work for palliative care, not for an organization. We work for to decrease the suffering of the people. That's I always say to the students and all. We should give voice for the voiceless. People doesn't have voice. People who suffer in rural community with the stroke or anything, they don't have even rehabilitation service in place. So many are being dumped into end of life care when there is a reversible cause also. So we have to think all of this, and only community will be the answer. Unless we train, unless we little demedicalize and decolonize or de-westernize palliative care, like we will be talking like this in 2050 also. So the best thing is do more and more of sensitization programs, make palliative care as a life skill. At least do's and don'ts of communications. How will you care for a bedridden people? And how can you understand what is the local resources in place? So this is the best thing which can happen. I hope so in future it will happen when everybody will come together. Thanks. Yeah.
Thank you, Dr. Mohan. And you have given a broad definition of community. So community is just not the people living in that area, but it's all the others who are supporting, like the NGO. So it's like something which it has to become in like sensitization of each and every one, so that the palliative care is inbuilt within the society itself. With that, so we have with us Dr. Ira Almeida, who is the project director, Serena Palliative Project in Goa. And Dr. Ira has been working a lot, taking a volunteer as a base. So volunteers are the backbone of the community, Dr. Ira. So how can we build a sustained, strong volunteer workforce for the community palliative care? So Dr. Ira has been a very reputed consultant in the field of pediatrics and community health, and her work has focused on her two passions, that is child and maternal health, and now she is taking care of the palliative care. She was the medical superintendent of South Goa District Hospital earlier, and now post-retirement she has taken this initiative as her one of the compassion. So Dr. Ira, to you, about talking about the volunteers as the backbone of the community for palliative care. Over to you, Dr. Ira.
Thank you, Dr. Ritu and HelpAge, for having me on this panel discussion. So just to give you a short background of what Serena Palliative Care is, it is an integrated service where we have a team that is supported by HelpAge and Cipla Foundation. And we work together with a team from the government side, which is the Directorate of Health Services. So this gives us a lot of leeway. It's a win-win situation for both. We have nurses, we have doctors coming from the health services, and we also have access, and we have a pain specialist clinic. So when we have difficulty with pain management, we have a good referral system there. Now, how did we get into volunteer involvement in palliative care? We started in Jan 23, and that year, the theme for World Hospice and Palliative Day was compassionate communities together for palliative care. So we thought, what can we do with communities? And at that time, we realized that we had started OPD services, we had started home care services, we had started IPD, which was bedside assistance in our hospital, which is a district hospital. But we found we were not getting enough patients coming to us. So we thought now we will move into the community. And we started working with panchayats. We asked the panchayats to identify volunteers, one each for each ward, what we call a ward in Goa, which is a ward, one each for each ward. And those volunteers, their job was to map out patients whom they thought would need palliative care. So initially, we just gave them a training of what palliative care is, but they would map out the patients in their area. We would go on the appointed day and see whether those patients were fitting into our program as per the NHM screening tool for palliative care. So if they fit, we took their signature, we entered them into a program, and then every month we would come and visit these patients. Now, why the frequency of every month? It was because these patients had low symptom burden. If the symptom burden was high as per the ESAS score, then these patients were transferred into our home care program. So every month we visit the communities. The volunteer coordinator maps has a list ready of all the patients we will see. The volunteers, we go with say 6 teams. The volunteers, then each volunteer accompanies a team, and they go to the houses and we visit the patients, provided palliative care. Now, since we can go only once a month for this program, we then ask the volunteer every week to be in touch with the patient and then act as an interface between, like if the patient needs any care, the patient needs any emergency treatment, to get in touch with us and we will facilitate that treatment. Now, this was one model where we worked with volunteers in the community. We have now 10 panchayats on board. And about we also have a different model called Kai Bare. Kai Bare is a different model, not panchayat based. Kai Bare and Konkani means how nice. Now, about 6 months ago, a volunteer, a lady, called me up and said, Doctor, do you only work with panchayats? I said, no, I'm open to any kind of community involvement. So she said, why don't you come to my village? I know that in my Vada, there are about 10 patients that would qualify for palliative care. So we explored that. We went there, and she did have 10 patients. But what is amazing is the age of this volunteer. This wonderful woman is 88 years old, and next month in Jan, she's going to be 89. So, like, there is no age, like Dr. Rajgopal said, it is what you need is will. So, similar when people approach us and on hearing her story, we have now another 3 more Kaibare models where individuals have taken up the responsibility of being the in between and helping us, source the patients and we visit them. So besides this volunteer, whether it is the individual volunteer led program or the panchayat led program, we also have other volunteers in our program. We have like a volunteer surgeon who's a retired surgeon. So if our bedsore management is getting difficult, she will personally visit the patient. We have a volunteer psychologist who also works with us to look after our self-care. We have a volunteer dentist who works as a dental prophylaxis program, where in the community we apply a fluoride application to prevent caries and a fluoride diamine, silver diamine application to arrest caries. So we have tried it out in few areas. We have like a volunteer medical officer. So anyone who comes up to me, I ask them, what is your area of interest? And depending on what is the area of interest, I say, okay, you could work with us in that manner. So I have a medical officer who works with us on checking. I say every Wednesday when you come in, you check 5 papers and see whether we have used any drugs, whether there are drug interactions. I've also given her another job. You check out of our deaths, how many have been a good death. So this way we can expand the depth of our work by using volunteers who are willing to come, willing to be trained, who already have expertise and would like to give a time. That's how we use them. Now, there are challenges also. One is that many times a volunteer will map out a patient, but the patient does not want to be helped. They say, no, we don't want your service. We know that the patient needs our service, but it is frustrating for both the volunteer and for us. The other thing is that sometimes we have a lot of young people wanting to volunteer, but their commitment is not, consistent. So we insist whether you give 1 hour, whether you give 100 hours in a year, it has to be consistent. And if you're not coming, you need to inform us. Also, we will call you a volunteer if you have done the online volunteer course that Palliative India offers, and we will give you an experience certificate if you have worked at least for 3 months. And if you want to come for a shorter time, then you will be an observer. So how do we keep our volunteers motivated? So this year we had a volunteer conference, and this was at a 5-star hotel. Because our idea was to appreciate them, to recognize them for the work that they are doing, and to keep them motivated. And the bill at this 5-star hotel, 75% of it was paid by the local panchayat. We also are looking to keep the volunteers, motivated. So for my future plan now is to identify a good volunteer coordinator who will periodically, maybe once in a quarter or maybe biannually, meet them and keep them together so they know they're part of a movement where they're making a big difference. Thank you.
Thank you, Dr. Ira. And then you have mentioned that volunteerism is not only about from the community, but volunteerism can be from the professional side, where the professionals can give their time as a volunteer and support in the community, and to have the sustainable solutions itself. Volunteer from the community and other professional is the key to answer, because the team cannot come from the outside to provide the care, but it has to be from within that community, and that volunteerism has to be built in. So there are many ways, and there are many ways to motivate the volunteerism. Thank you so much for that. And so we know that when it is scaling up for the any kind of care services, we have to look at the government. So we have Mrs. Timothy Poracodi, who's a Deputy Director, Health, Cuddalore District. And Madam, for you, I would request that please give us the overview that how can we scale it up at the district level, and how can we converge it at other levels as well.
Good evening to all the dignitaries on the dais and off the dais. I'm Dr. Porkodi, District Health Officer or Deputy Director of Health Services for Cuddalore District, Government of Tamil Nadu. And I thank the HelpAge India for providing me the opportunity to be here and the honor to address you all. Thank you. This palliative care comes under a long-term care initiative of the government, and it actually aims to provide comprehensive care, that is psychological, mental, physical, or whatever care is needed for the palliative care patient as such, and also train the primary caregivers of the family to handle them in the long term also. Since this long-term care falls under the ambit of non-communicable disease control program of the government, because there are various programs like mother and child health, communicable disease control program. So this falls under the ambit of non-communicable disease, which is the current outbreak mode of disease spreading in the community. Now, lifestyle diseases, we have controlled all the communicable diseases to an extent with all the latest drugs and information systems and outbreak responses. But the lifestyle diseases is becoming a challenge for us now. And in Tamil Nadu, as per the estimates, around 7% of the population needs palliative care. 7% of the population. And 10% of the population is under the geriatric age group. That is a dependent population, and resources are needed. And at the level at the government level, policy decisions have to be made to scale up all the to scale up the activities needed to provide a comprehensive palliative care. And with information asymmetry, government tends to step in, and palliative care is another area where the government has taken priority. And this I wish to go back a few give an overview of the non-communicable disease program in our setup. The non-communicable diseases program was launched in 2010 by the Ministry of Health and Family Welfare, Government of India. And of course, it was expanded in a phased manner throughout India. And HR were recruited, resources, equipments, and facilities, infrastructure was provided. And here in Tamil Nadu, the major difference is that Government of Tamil Nadu has a well-defined Public Health and Preventive Medicine Directorate, whereas in other states in India, it is either merged with the Director of Medical Service or with the Director of Medical Education. Here, the medical officials and staffs get recruited in the system, they get promoted, and they stay within the system. So this is an exclusive system catering to the needs of public health and primary prevention. So we have, unlike other states, we have a lot of community-based, not an institutional-based, community-based programs, so that the reach is quite high compared to other districts. So in that manner, we launched Makkalai Thedi Maruthuvam. That is services, medical services or healthcare services at their doorstep in the community. That was launched in 2011 and 2021. It's there for the past 4-5 years. So in that program, we had framed some guidelines for mobility support and the HR recruitment and what are all the activities under their purview. So this Makkalai Thedi Maruthuvam in only it only initiated the involvement of women health volunteers. These are all at least school educated volunteers from the same community, preferably women, either married or who will be staying there for at least 4 to 5 years. These girls or these women get trained in our system about a simple task like checking BP and measuring the glucose with glucometer. And of course, we do have a flip chart of 10 conditions which they are supposed to screen the people in the community door to door every day. They have to cover at least 20 persons in a day or at least 10 houses in a day. These are the women health volunteers, and they maintain records. So these conditions, obviously, the first top 5 non-communicable disease conditions given focus in these days, that are diabetes mellitus, hypertension, cancer, cervix cancer, breast, oral cancer, and apart from that, tuberculosis and leprosy, which are national health programs in the control stage and elimination stage. And then CKD, chronic kidney disease, COPD, mental health, all these are included. All these 10 conditions are screened at the doorstep by the woman health volunteer who gets a training, and they do get a flip chart with all the colorful pictures so that it's easy to explain and get them screened. Apart from that, we do have a vehicle. It's a car with one physiotherapist and one palliative care staff nurse for each block. If when we talk about Kadalur district, it has a population of 28 lakhs. And revenue-wise, we have around 10 taluks and 14 blocks, development blocks. So with each block, we do have a block primary health center and all. So for each block, we have hired vehicle with palliative care staff nurse and physiotherapist whose job is to go door to door with on an ATP, based on an ATP, advanced tour program. So far, since the inception of the program in 2021, we have around um, 18,000 palliative care cases since 2021. And for physiotherapy, we have around 27,000 enrolled. Of course, it is a dynamic number. People will come into the system and people will move out when there is a death or when they get cured. So we have these many patients in our system who get visits paid by the physiotherapist and palliative care staff nurse with the as a mobile team, apart from the MTM volunteers. So now for convergence, there are other social security measures like old age pension, widow pension, of course, for filaria, grade 4 filaria patients with lymphedema, elephantiasis. They can't be mobile as others. So we do give an allowance of 1,000 rupees per month. Also, old age pension, I think right now it is around 1,500, and a widow pension. There are other social security measures. So these also have to be facilitated for those people. And many of the palliative care people may not have attenders. So for them, such minimal allowance helps for their transport care and all. So these other social securities have to be taken care of. Of course, the district administration will be the coordinating authority. So in monthly review meetings, they can look at the performance and how many have been included in this program. And also the community-based organizations and the NGOs, they do have their own resources, and they can actually take care of one particular activity and give a comprehensive care in that field. As I said, our team, the services provided by our team are end-of-life care, nutrition advice, then evaluation of physical and mental symptoms, because we have a national mental health program with 2 psychiatrists. So they also come into the picture to give them care. And also psychosocial support of the patient, then intubation for feeding, catheterization, wound care, mouth care, bowel care, lymphedema care, as I said, in elephantiasis cases, and then pressure source, IV fluids whenever it's necessary. So all these services come under the care, continuous care needed for those palliative care patients. And we have the system here in the government is like At the primary healthcare level, I told you about this mobility mobile team, and the women health volunteer. And of course, with universal health coverage policy by the government of India, we do have mid-level health providers who are staff nurses at the health subcenter level, and they actually run outpatient services in the sub-center, which is very accessible to the patient. Unlike a GH, which is in the headquarters, this will be in their own village. The health and wellness, the health sub-centers with the MLHP are upgraded as health and wellness centers, and they should be having around 106 drugs, 106 drugs at the village level. And they should be providing 14 lab services, minimal lab services, that are hemoglobin check, RBS, blood sugar, BP checking, malaria, a fever smear, and all these 14 minimum mandatory tests done at the periphery. So these are the services provided at the primary healthcare level. And we do have palliative care clinics in the government hospital, GH, as well as medical college. So again, for scaling up, there should be a proper linkage. We identify at the community level, the VHNs, the MLHPs, they do have a indicator list. If they have such symptoms and signs, they should be referred, and they get confirmed in the primary healthcare level, and they are referred to the secondary and tertiary healthcare level, and from them we do get a feedback. So of late we do have all these social media platforms, especially WhatsApp, so that immediate follow-up is given. And of late, the government has organized one organized cancer screening program. We do screen, it's like a combing operation. None of the women above 30 years is left. We do motivate them, we do give them invitations, and ask them to come to the health and wellness center to get themselves checked for CA cervix. We do via screening, acetic acid screening, and then clinical breast examination for CA breast, and oral cancer with staining with toluidine blue. This program has been also started here in Kadalur district. So preventive aspect is also important. Screening and early diagnosis, so that we catch them in the early phase, and so that management becomes easy. And instead of letting them progress and having them come to us in the third or fourth stage. So prevention and screening for early diagnosis also makes a big difference in reducing the burden of palliative care in future. Thank you.
Thank you, Dr. Kodi. So yes, we know that now you have mentioned that 7% of the population needs palliative care, and this is much more in when the people are aging and having suffering from the non-communicable diseases. So the crux of the talk which I have taken is like best referral mechanism, early identification, and the community coordination, and the coordination within the health system and the community itself is something which has to be there to provide any kind of services. So this is something all the health systems are far much better in southern states, and this we have been evidencing from many decades of now. But there are different contexts and geographical diversities there, and there are certain north areas where we see that it is not so better. I would not say that it is not there, but it is not so better, and the implementation may be very difficult. So we have with us Dr. Umesh Badani, professor and head anesthesiology, AIMS Patna. I hope he's online there. And yes, so Dr. Umesh Badane is anesthetist and critical care and pain management specialist, and is a he has been a long-standing contribution to this area, and he has been providing that care into the service delivery at AIMS Patna. So, Dr. Badane, I would request you to give how it is different from southern state, the palliative care in northern state, how it is different, and what are the challenges or what are the good practices we can take from southern states. Over to you, Dr. Badani.
Ma'am, he need to unmute himself because he's there, but he need to unmute his mic and as well as video.
Dr. Badani, please unmute yourself. We are not able to hear you. Dr. Badani, can you please unmute and switch on your camera? Okay, by the time Dr. Badani comes over and he has some technology issues. So I'll request we have Dr. Rima. Dr. Rima is from IGMC and Dr. Subita from JIPMER. So Dr. Subita, because you have in JIPMER, you are also looking at the patients and coming there. So how do you see what is the difference? Where should be the coordination should be there, and how can multidisciplinary approach be strengthened for the palliative care and for the community palliative care?
So I'm basically from the community medicine background. So we have a very strong hospital care team. So the hospital team functions that when the patients come to them, service is provided. So there is a lot of coordination happening over there. So we work in the community trying to identify patients with needs and provide them with care. So the linkage is very crucial. So how we are going to link and refer them so that they are not lost in the pathway or they don't get fatigued in the pathway, because this is a long-standing one. So beyond providing care in such tertiary setup, there is a need for more of outreach clinics, and therefore the need to strengthen the PHC team, the primary healthcare or the subcenter teams in that aspect. So therefore the need for capacity building the healthcare workers, as Dr. Kavita was mentioning, it's more in the ambit of the medical colleges as well as the state government programs to train and strengthen them. And each of these institutions also can further start pre-service and in-service training as well, because it starts with undergraduates from all cadres, from all disciplines, not only medical, so nursing and these. So again, in JIPMER, we are trying to include that as part of our undergraduate training curriculum across all the disciplines as well, and trying to give a more stronger focus during their training period with them. So this is how we function. We are experimenting some models of where telelinkage is possible along with the outreach visit. So we are in the early stages of discussing with our clinical teams as well. So maybe we'll be able to share more when the teams have matured in that aspect. Thank you.
Thank you, Dr. Subita. We'll look forward to those models. And Dr. Rima from IGMC, you have certain models?
Actually, we started our program in 2023 as a small project. We started as an outpatient unit. We started. Right now, we have a inpatient unit of 4 female and 4-bedded ward is available. In case of respite or for terminally ill patient to have an end-of-life care, we provide that. And we have a regular supply of morphine. So from any part of Pondicherry or outskirts of Tamil Nadu, patient used to in fact come from Pondroti also, ma'am. So we used to receive patients. We don't see the borders and we give them morphine and supportive care. Even we admit those patients who are not able to bear the pain and have the end of life care in their place, because it's difficult for them to get attention, and the family is not able to bear seeing the pain of the patient. They are not able to bear. Those patients we used to support. We in fact had few pediatric patients also in end of life care. We had provided for them also. We are also having all the other programs for like ASHA workers, like what Kavita madam had told. We are trying to develop further.
Thank you, Dr. Rima. So we will wait for Dr. Umesh for a few seconds, but by the time, because Dr. Porgodi has to leave urgently and she has requested, so I'll request my colleague Pradeep to give her a moment, a token of appreciation. Thank you, Dr. Porgodi, for your presence and for giving your the view. Thank you so much. So any questions from the participants till we give the final moments and we so Dr. Umesh is here. Dr. Umesh, uh, I hope now you can hear and we can hear you.
Yeah, I can hear you. Sorry, because I had come to Jamshedpur for taking exam of MD, but now I am free. I finished that. Okay, I am available now to talk to
Thank
you
you.
people. Thank you.
Okay, thank you, Dr. Umesh. So I was sharing that we have different perspective in a southern state for palliative care, and we have a little more advanced and supportive health system in southern states. But there is a little geographical difference in northern states. So I wanted to understand from your perspective. You have seen in AIMS Patna that how it is different in northern states when it comes to the palliative and supportive care. Over to you, Dr.
Thank you.
Badani.
Yeah, thank you. I must thank first the Helpage India for giving me this opportunity to tell about my place. Yes, there is a basic difference between southern state which I could gather. Like in Kerala, there are a lot of aged and senior population, and most of the families are nuclear family. There are very few persons to look after the persons in their family. But yes, society is a very big thing in southern states where society takes the responsibility of palliative care. In contrast, in northern part of the India, still there are a lot of joint family, you can say. So still in the villages, there are 15 people, 14 people, 16 people living in a home. So we here not in a exactly that much of need, because there is somebody in home to take care of the person most of the time. But the situation of palliative care in this part of India, that is Bihar, is not very good. uh, First, the our experts don't understand the situation that this patients needs palliative care, and they keep the patient for very long time with them, and they don't refer it. Then public also don't know that there are facilities of palliative care. Hardly there are palliative care services in the Patna. So they have to travel a long distance to come to Patna. Now recently Muzaffarpur, the Tatas, means there is a Homi Baba Cancer Hospital is opened up, and there is the palliative care, and there are hardly 3-4 centers in whole of Bihar where palliative care facilities is present. So that is the situation. And in AIMS Patna, we are having 18 bed of palliative care ward, and we are running OPD also. We had made a committee from the various specialists of various hospital, and we give a proposal to government of Bihar for palliative care policy. It is still in the developmental stage, but yes, people are very much now receptive to palliative care. And I want to inform a very important information that government of Bihar has sanctioned 112 crore rupees to open a palliative care center and hospice in Muzaffarpur, and they had donated 112 acres of land also. But yes, at the village level, at the grassroots level, there is still, it is lacking. There is hardly any network or any NGO working at the grassroots level. Most of the palliative care is concentrated at the family level only. And as I told in the beginning, that is still this is not nuclear family here, but joint family. But somehow people take care of their person or family members in a very good way. So that way, but still there is a long way to go, and we have to recruit and train many of the persons in the grassroots level or volunteer level to make palliative care reach to each family and the villages and other things. Fortunately, now roads are now better, so it is now well connected. We can spread this teaching and training to the volunteers in coming days in Bihar. We have trained doctors and nurses in 21 districts through Homi Baba Cancer Center and in collaboration with Government of Bihar. So that way we can tell that in Bihar, I can summarize my thing that the higher tertiary level palliative care is concentrated in the capital state of Patna, with AIMS Patna, IGMS Patna, Mahavir Cancer Hospital are the main centers which is providing care of palliative care and imparting training of palliative care. AIMS Patna and IGMS are centers for training through IAPC, Indian Association of Palliative Care. So we are training both nurses, doctors and volunteers in these centers. We have trained about more than 300 doctors and nurses in 21 districts of palliative care, and we are in process of arranging morphine to be available in all districts of Bihar. You all know that to make a morphine available, we require a lot of law and order homework. So that we are in the process of giving that, and hopefully within coming 6 months to 1 year, we will have the centers of palliative care with one doctor and two nursing staff trained in palliative care in each districts of Bihar. So I think by this we can summarize that still we are very much lagging behind in comparison to southern states where community role is very much important and prominent, and they are taking responsibility of palliative care. But in Bihar and UP, still we are very much behind in giving palliative care services to the needy people. There are about more than 7 lakhs people who need palliative care in Bihar, and unfortunately, we are not able to provide more than 3 to 4% of the persons needing palliative care. I think this, I am now ready to take any questions if anybody want to ask regarding Bihar and northern part of India regarding palliative care services.
Uh, Thank you, Dr. Umesh. And there is a different context of the family. And yes, in the north there are few palliative care services, but steps are being taken, and I'm sure over the years we will have more and more centers, and like persons, professionals like you are taking that step, and thank you so much for that. So. If anyone has any comment from the participants before we go to the next session, uh, we can have questions from our panelists, or anything you want to share from your experience. We have this opportunity for 1 or 2 minutes. Okay, so it seems
Main roadblocks which I am facing is the
yes.
availability of opioid, morphine, and other drugs in the periphery. And yes, the trained volunteers are very much unavailable. But yes, the role is being taken over by the family members, because most of the places are joint family. So we train the family member and they take care of the palliative care.
Thank you, Dr. Umesh, for sharing those roadblocks. And with this, we close this section, and we would like to honor our panelists. May I request my colleague and Rohit to just come here and honor our panelist, Mrs. Dr. Kavita Vasudevan. Yeah. Dr. Annie. Dr. Mohan. Dr. Subita. And Dr. Rima. Thank you, Rohit. And I would request now our colleague Kanchan Sen to give the brief summary of what we have understood, what we have learned during the session. Over to you, Kanchan.
Hi, everyone. So from 1:45 to about 3:45, I think we had a info powerhouse on palliative care. And I think we've had one of the best minds of the country speak in the last 2 hours. And I think uh, from the national policy space to a state space to a practitioner's context, and I think also to the space where how CSRs is shaping the space. I think all of this truly, I think we've stood to the heading of our event, which is strengthening community palliative care. And I think thank you everyone for also being there. I think palliative care is definitely a huge need, and as someone said, that it's not just a specific care, but it's more of a life skill, as you said, and absolutely correct. And while Dr. Said that the 70% of the elders are abandoned, and it's really a bit of a glum number to really talk about. But I think there's also some good news when people talked about that there is this aspect of North India still having the family structure supporting that space. So all of that put together, I think I'm very happy to share that together. I mean, we are truly, I think, co-creating, collaborating together to create different models of palliative care. And it was lovely to hear about the 88-year-old volunteers, the human health volunteers. So overall, I think a lot of new ideas. I mean, we do run a lot of mobile health units, and when I heard about the mobile palliative units and all of that, so these are great learning. And before I end, I just want to say that alone we try, and together we thrive. So I think let's keep that to our heart. And maybe I'll call upon Kunal, who heads the mission Age Care in Helpage, to probably give a vote of thanks. Kunal.
Thank you, Kanchan. I had to take some notes to make sure I don't miss important names. So first of all, Malai Varakkam. Good evening to everyone. So as we conclude, like everyone has already said, today's dialogue has shown us that palliative care is about much more than medicine. It's about kindness, community, and dignity. So Dr. Rajagopal reminded us to care for the whole person, not just the illness, by bridging the gaps in our current system. Our expert panel, Dr. Annie, Dr. Mohan Raja, Ms. Porkodi, Dr. Kavita, Dr. Hema, Dr. Subita, and Dr. Ira shared powerful hands-on insights, proving that a strong community is the best way to ease the pain and loneliness of our elders. We also thank Mr. Sundarajan for representing the local administration and supporting this mission. Ms. Pooja Singh highlighted how Teva leads with compassion, encouraging employees to personally support those in need. Dr. Bhatnagar then reminded us that relieving suffering is a deep-rooted Indian tradition, aiming to make the end of life a peaceful experience. Dr. Badani from AIMS Patna shared vital insights on how we can practically apply these traditions within our modern medical institutions to ensure no patient is left in pain. I would now like to officially thank everyone who made today possible. Thank you to our speakers and experts for your wisdom and for showing us how to build a more compassionate healthcare system. A sincere thank you to our leadership team, Rohit, Pradeep, Kanchan, Dr. Ritu, everyone else here, and to entire team working in front and behind the scenes, including from our IT and other support staff. From the colleagues organizing to the staff who kept everything running smoothly, we truly appreciate your hard work. A special round of applause for Edwin, Ramalingam, Satya Babu, and Muthu, and many others who are in front and behind the scene. Finally, a very special thank you to our community members, both in the field and here at Teva, and here at the TV. You are the ones who turn these values into action every day. To our audience, to all of you, thank you for joining us and for your commitment to this cause. Have a wonderful evening. Thank you.
We will all join for tea and small snacks. So with this, we close it. Thank you all. Thank you so much.